So now we are trying to move into the treatment modalities and treatment, and I will, slowly go through what. This is based on our perspective in the book. This is not scientifically documented, but this is sort of a way we are thinking when we treat patients with periimplantitis. So we have now a patient with a diagnosis of periimplantitis. The first decision, I think, to be taken is, are we going to keep the implant or are we going to remove it? In some situation, it is really better to take the decision to remove it, and then we do that initially. Otherwise, if we decide at the first situation we meet the patient that no, we will keep the implant, then we always do non-surgical therapy. And maybe you will wonder why, and the main reason is that we would not like to do surgery with a very inflamed tissue. We would like to have the inflammation to go down. We also would like to have some feeling for the patient's ability to really respond to the treatment, and also see if the patient is willing to cooperate with the treatment we are offering. So we do the non-surgical therapy. We do a reval after that, and it happens that in some cases the infection is controlled. I mean, we got healing, although we have only performed non-surgical therapy. If so, the patients go down here to the maintenance schedule, and we assign a patient an individual maintenance therapy. And I could already now say that when we have patients in our clinic that have had periimplantitis, they always go every third month for maintenance, because we consider them as high-risk patients. And there are so few studies published long-term in the prognosis of treatment of periimplantitis. So we feel that the ones that have really developed this disease, we would like them, to be well controlled in our practice. Okay, then sometimes, or most, in many cases, we are not so successful. So although we've done non-surgical therapy, the infection is not controlled. We then look at the soft tissue conditions. Soft tissue conditions are there any keratinized gingiva present? Do we feel that we need to make adjustments of that? Yes or no? If it is not adequate, and we feel that when we do a surgical procedure here, we will have a tissue that will pull or things like that, we may decide to do a gingival grafting. If we feel there are adequate soft tissue, we go down and we do some type of surgical therapy. It do not need to be regenerative. It could also be resective therapy, but we do a surgical procedure. So first is now to decide, are we going to keep the implant, yes or no? And as I told you before, if we have this type of situation, we have two distal implants. I have used, those endodontic points, so we can see that you can put them down here almost to the base of the implants, both of them. And when we just cut through the bridge, you can just do like that and lift it out. There is absolutely nothing holding those implants. They were there only because this one was holding the bridge. So it is no use to try to treat these type of situations. Another situation where you also may decide just to extract is when it looks like this. This is a patient that has been through regenerative surgery before, and she has 3 implants, and you see the middle one has lost most of its osseointegration, but even the other ones are not in the best shape. So in that case, we decided to remove the middle implant. And please, you can see here that you have non-integrated bone substitute here. And I would like just to point out, even before we come into the regenerative procedures, that if we have a tendency to overfill with bone substitutes, and it may be just included or incorporated in the soft tissue, and then it may be a foreign body reaction. So here we decided that the middle implants could be removed. And then we made some bone augmentation procedure on the mesial of that implant. This is often, this you can say, but this is not the norm, this is not the way you said before, it's always circumferential, and it is, but now when you have a tooth like that, and we have another example here, you have 3 implants like that, remove the middle one, but the tooth is retaining a lot of the bone. And it's difficult, if you are going to keep those implants, which you can discuss, of course, should we really keep that or should we remove it? But if we remove it, then we have to do something else. We cannot use the superstructure, patient cost and things like that are things that we have to put into the equation. So it's not so easy always to decide. In this case, we used the BioOS collagen here on the mesial just to try to get some osseous defect fill. I'm not sure it's going to be bone, but there will be some kind of defect fill here, and to hold the mesial part of the soft tissue, and then make a resective type of surgery in the distal one and also on the distal of that one. So sometimes it's not so really straightforward. As this scheme may give you the impression, we have to take each and every patient's situation into consideration, and also the patient's ability to pay for the procedures. But basically the basic principles for treatment, when we now have decided that we are going to treat, we are not going to extract or remove the implant, the basic principle is to work with infection control and also then try to treat really the etiology of the disease. The second one is to avoid a re-establishment of the microflora. So the patient needs to be able to obtain an adequate oral hygiene in the area. And then first after that, we can consider to do procedures where we are aiming on either trying to make, a regenerative approach with some type of regeneration of the lost osseointegration, or we do a resective approach and an apically positioned flap in order to make it easier for the patient to clean the area. So first of all, then we look in the mouth. We see, are there any periodontal disease on the teeth, if the patient has teeth present. If so, we treat the existing periodontal disease. Then we have to look at the prosthesis. Do we have to make adjustments of the prosthesis? Of course, we need to improve the patient's oral hygiene. So they have to go through an oral hygiene program. We have to look what type of devices are needed for them to be able to obtain a good oral hygiene. And then we, as dentists, are now going to try to remove the biofilm. This is just an example of a patient that needed some, so-called infection control. The patient has a molar, tooth-supported bridge, and an implant-supported bridge. And if we look more close to the molar, you can see this is the way it looks. Advanced periodontal disease. From another angle, from a radiograph. An infection control in this patient is this. We remove it. I mean, sometimes we have to tell the patient we cannot keep these type of teeth because they are really just a source for infections around the non-infected implants. We talked previously about these situations with superstructures that make it impossible for the patient to clean. Of course, this patient has no possibility to clean here at all, and if we look at the radiograph, there is periimplantitis. So remove the prosthesis, adjust the acrylic. This patient has, of course, in these areas, this patient is not capable of cleaning, and it is an obvious risk to develop periimplantitis. So the acrylic has to be taken away, so they now can obtain adequate oral hygiene procedures. We are really reinforcing the oral hygiene in our patients because we feel it's fundamental to the success of any treatment we do on these individuals. So if we now look at peri-implant mucositis, there are different ways to treat it. And I would like to really reinforce that you diagnose not only peri-implantitis, but also look for peri-implant mucositis. Because treatment of peri-implant mucositis is quite predictable. It's not so difficult, and in many cases it really works. If we wait and we allow the disease to continue and develop into peri-implantitis, the treatment modalities are more complex and not so predictable any longer. Treating peri-implant mucositis, there are many different non-surgical therapies you can use. You can use this one, which is the airflow device. So this specific one is the PerioFlow system from EMS. You can use curettes designed for working around implants, and design is not so very specific. The only design issue is that it may be in either plastic or it may be in titanium. We prefer to use titanium instruments because they will have the same hardness as the implant, which we feel is an advantage. There are studies available demonstrating that if we are using softer materials, then there is a risk that there will be remnants of that softer material in the pocket after using the softer material. So this is our reason for using titanium instruments, hand instruments. But as I told you, they are not the most well-designed things to use around implants, as you may of course know. There are ultrasonic devices. These ones, I'm just demonstrating this one for you to get an idea of the dimensions between the implant and the tip. Those are not really easy to get down there, and also they are of the softer material. For me, I think maybe they are not really the best ones to work with. I rather prefer to use the hand instruments or the PerioFlow. Another option, of course, is using laser devices to use around the implants. Also, if you look at the dimension on this specific tip, it's a sapphire tip, and it's a YAG laser, and even that tip is quite big and bulky, and it is, in my mind, difficult to use when you have the superstructure in place. I rather would like them to take off the superstructure, but that also is time consuming, and time is money, and this will cost more for the patient, of course. But if we look now at treatment of Periimplant mucositis. That was a recent publication by the group of Klaus Lang with Lisa Mayfield as first author. They had 29 patients with which they randomized into two groups, and they used one implant per patient with periimplant mucositis, but they had no loss of bone. Measurements were done at baseline, 1 and 3 months on these individuals. And the two treatment modalities that they used were they had, all of them had oral hygiene instruction and non-surgical therapy. And then in the test group, you had a chlorhexidine gel, and in the control group, a placebo gel. And what they found, after 1 month, they had significant reductions in the number of sites with bleeding on probing and mean probing depth at implants, but there were no difference between the groups. And you can see the BOP positive sites at baseline and 3 months. At baseline, you had none of them with zero bleeding, but in 3 months, you had 38% of the implants with zero bleeding, indicating that they were healthy. So the authors concluded that non-surgical therapy was effective in reducing periimplant mucositis. So I think this is a really good take-home message. We can treat periimplant mucositis. And they found a complete resolution in 38% of the cases, but they also saw that using chlorhexidine gel as an adjunct to the mechanical therapy did not improve the therapy further. And now, just to sum up some other studies on non-surgical therapy, you see the first one we've talked about, that chlorhexidine do not improve it. And there has been a study published in 2012 by Hallström et al. Showing that the adjunctive use of generalized antibiotics do not improve treatment results. So there is no need in mucositis cases to use generalized antibiotics. And just to show you now two different treatment modalities of periimplantitis. We are now moving from periimplant mucositis to non-surgical therapy of periimplantitis. This is a randomized clinical trial. We did at our laboratory 31 subjects. We had one qualifying implant per patient. And you see it has a probing depth of more or equal to 4 with bleeding on probing and pus, and less than 2.5 millimeter of bone loss, because we didn't want to involve too advanced cases and see how do non-surgical therapy work in these type of cases. So we did clinical measurements, and we had a pressure sensitive probe, and we probed 4 sites around each implant. We tried to grade the bleeding from 0 to 3. So no bleeding. We had a point or little bleeding like this, just a point of bleeding, a line of bleeding, or profuse bleeding. So we checked patients before 1, 3, and 6 months after therapy. Group 1 were treated with titanium hand instrument. Group 2 with those ultrasonic device with a plastic coated tip. And there were in both groups a significant improvement in the bleeding on probing. You can just see like this that we have bleeding scores. Drop of bleeding is the red, and this is hand instruments before, after, ultrasonic before, after. So you are reducing the amount of bleeding, and you also get some sites with no bleeding in the ultrasonic group after 6 months. The probing pocket depth at the deepest sites, you see there is really no change at baseline, 6 months with hand instrument, baseline, and 6 months with the ultrasonic. There is really no change in probing pocket depth. And looking at the microbes, there were a little bit reduction after 1 week in the hand instrumented group, but otherwise no really difference. So if we try to sum up, we can say that both treatment modalities were not really effective in treating even moderate advanced periimplantitis. This is from the group of Frank Schwarz. He has published a lot, and this is on the use of either YAG laser, the ER YAG laser, or mechanical debridement in conjunction with irrigation with chlorhexidine of the defects. And based on only then 10 laser treated and 8 control patients, he found that the probing pocket depth reduction and clinical attachment level changes were similar in the both groups. He found that the bleeding on probing was more reduced in the laser group, and unfortunately plaque index was significantly higher at 12 months, indicating that the patients really were not attending to the oral hygiene, which may hamper, really understanding the results from the study. He also found that there was an increase in bleeding on probing scores and loss of clinical attachment level between 6 and 12 months. I think this demonstrates to us the importance of the oral hygiene if we are going to be successful, no matter what type of therapy we are really doing to our patients. For us as clinicians, I told before that one thing we are trying to do is that we are trying to decontaminate the surface. But we are also, as I said, using maybe materials that are not properly made for doing that. We have a surface looking like this, and we are using instrument looking like that. And of course, this is extremely difficult to be able to clean within all those, different irregularities on the surface, and all surfaces, depending on what type of material, what type of implant system we are using, may look differently. So what we are trying to do with different modalities, like an ordinary, curette, titanium curette, a titanium brush, airflow, or something. This is airflow. We are facing this problem. This is what we are going to remove on the implant. And then this is now an old Brånemark implant with a lot of mineralized deposits. You should now think that this is a surface, medium rough, where you have all those irregularities, and we are trying to remove that. And we still have the soft tissue all around the implant. It is really not very easy. We tried to look at the use of this YAG laser, since it was demonstrated by the Frank Schwarz group that this could be of some benefit, and compare that one to the use of the PerioFlow systems. So we had in all 42 patients, and we had 55 implants treated by the laser, and we had 45 implants treated by the PerioFlow. They were all bleeding on probing, of course, probing depth more or equal to 5, and they had more than 3 millimeter bone loss assessed from the intraoral radiograph. And this is now from the laser group. let's see if we can get the video going there a little bit. Yes. So this is, as you see, we removed the superstructure. Still, I want you to see at the dimensions of the sapphire tip, and you could, in your mind, envision how difficult it could be to be able to reach 360 degrees around the implant with that type of tip with superstructure in place. It is not easy, and we have to acknowledge that this is sort of one of the problems with these type of tips. Although, in spite of in this specific study, we found positive things using this. You can see from this clinical slide the hyperplasia here at baseline, and already 2 weeks after you have a recession, you have really a reduced probing depth following the use of this laser apparatus. The other type of treatment modality that we evaluated was the airflow device, the Periimplantitis. And let's see if we can get it working. Yeah. As you can see, they are quite deep defects, 8-9 millimeters deep, with bleeding on probing. We also removed, of course, the superstructure in this case, so they should all have the same, situations. I think you can see in this small video clip that, and this is the first version of their tip. The newer tip is smaller, thinner, and easier to apply. But even this one is bendable, so it is flexible and it's more easy to use than the non-bendable laser apparatus. Here are the results, baseline values. You see bleeding at baseline, almost all of them. Probing depth at baseline, around 6 millimeter in both groups. Plaque index 35 and 22%. And look at bleeding scores at 6 months. You don't have to look at the percentage or anything. You can just look at the colors, because red is the drop, green is no bleeding, and these are baseline values, and those are 6 months values for the laser and for the Periimplantitis. You see that there is an increase of the green, a clear reduction of the red. So both had a positive effect on bleeding, on probing, both treatment modalities. And here you see the reduction of pus in both groups. The pus was reduced by 62 and 54% respectively, and probing depths were reduced between 0.8 and 0.9 millimeters in this group. So, and there is just a case demonstrating that you really get a reduced bleeding, probing depth following therapy. And of course, we looked in this study also at the microflora and see if there were any differences. You see it's very, very minor differences. At 1 month, there were a few bacteria, Fusobacterium, that were reduced in the laser group, and in the air-abrasive group, Staph aureus, Pseudomonas aeruginosa, and Staph anaerobicus were reduced in the air-abrasive group. But the interesting thing as such was that Porphyromonas gingivalis counts, they were higher in cases with progressive disease. So because, of course, in some of those advanced cases, it didn't heal. There was a slight progression over the healing period, and this was related to the presence of Porphyromonas gingivalis. And both therapies showed at 6 months that they were not able to reduce the bacterial counts. So moving into other options for non-surgical therapy, there are very few. I don't know in Germany if there is availability of local antibiotics. We have done a few studies on one specific local antibiotic that is available and approved in Sweden. It is minocycline microspheres. The product is called Arrestin. We started to, first study we did in 2006. We have just now finished together with a number of other sites in the US and a few sites in Europe, a multi-center study on the use of Arrestin. I don't have the results, so I cannot report that one. But I can show you in this one, we had randomized clinical trial. We compared the use of those microspheres to the use of chlorhexidine gel, and treatments were performed 3 times. Baseline at 30 days, at 90 days. So you have 3 treatments in both groups. And these are the results. We have a reduction of probing depth, and it's more pronounced in the Arrestin group than in the chlorhexidine group, and this is statistically significant. But still, you must agree that the reductions are modest, even in the active treated group, so to speak, with the Arrestin. So we are really not having a perfect, in that study, a perfect result. Hopefully, we will see something positive in the multi-center study, but I don't know. I will just show you a case. This is one of the patients we were referred to us for treatment of periimplantitis in region of 1-2. She were healthy, no medications at all. So she were offered debridement using both ultrasonic and hand instruments of this area. And then we used the Arrestin. This is just to show you how it works. You are using a specific plunger. You are pushing this powder down into the pockets. When it gets into the pocket with the moist, it gets a little bit harder, and it stays there for something like 7 to 10 days in this area. And during that time, the minocycline is dispersed in the area, and this is the effect you have. And this one, you have a baseline and 6 months data. So we had yellow here means that it's pus. 6 is in the figures in red means that it's bleeding. So we still have some bleeding, although we have a pocket reduction. But I think also you have to agree with me that following this type of treatment, I do not see the need for doing surgery in this area. I mean, so yeah, I could really avoid doing the surgical procedure, which I feel is an advantage in the aesthetic zone. And I would rather have this patient on frequent recalls and see that it doesn't come back. And eventually I would have to retreat it again using the same type of therapy. So summing up now for the non-surgical treatment of periimplantitis, unfortunately, we have to agree and say that it seems to be ineffective in the treatment, at least in advanced cases, that the use of the YAG laser, subgingival airflow devices, and local antibiotics may be beneficial. And I think this is one of the main reasons also why we always tell our referring dentist to start out with non-surgical therapy. Because in some cases it heals and you don't have to move on to surgical therapy. However, if you have very advanced cases, surgical therapy may be necessary and may be preferred.